Well, welcome everyone. It's my absolute privilege. My name is Bruce Moore. I work as the Director of Mission for a large community service agency called Uniting Care Queensland. And it's my absolute privilege and pleasure to welcome you along to our Greening the Healthcare Sector Forum today. I want to particularly call out those of you that are joining with us online today as well. We've got our online community. And, as I look into that camera up there, please feel so welcome to be joining with us in this way. Equally, those that are joining with us in this auditorium as well. As we begin today, I want to acknowledge the country on which we meet, and we acknowledge that we live and work on Aboriginal and Torres Strait Island countries today. And I want to pay my respect to elders both past, present and future. And in doing that, I want to recognise that Australians, First Nations peoples have cared for this country for over 60,000 years and have long recognised the interdependency of ecological, spiritual and human health. And in doing that, we acknowledge and respect the deep relationship between Aboriginal and Torres Strait Islander peoples and their ancestral lands and seas. We recognise the custodianship and contribution of our First Nations peoples continue to make to conservation, climate action and the management of lands and waters. Well, friends, there's just a few housekeeping things that we've got to get in order to ensure that we have a really a great day together. Whether you're joining us online, I've got some information for you, or whether you're joining us in this auditorium, just need to call out a few things. I hope you've come armed with your water bottle, because in an ecological, responsible way, we want to be responsible about how we might consume those things that we need to support us. So I'm being told that there are filtered bubble water that's out in the front there if you want to go and refill your particular devices or bottles that you've brought. If you need to find yourself in a way to the bathrooms or those facilities that are really important, I believe that they're located on the left-hand side of the main entrance as you have come in. And in case of emergency, want to point you out that we've got some exits on either side of this front staging area, and you'll be guided and ushered out that should we need to be led in that way. If you're zooming in with us in your online platform that we're using, I would like to tell you that you're really welcome to use the chat function and make comments and share information to those online attendees in the community that we have there today. But can I just make one ask of you, that you please don't post your questions for speakers, because we're using a different platform here today, and shortly I'll introduce you to how you might be able to use that, and it's called Slido. So a little bit more coming shortly around that, but if you can just refrain from asking questions through our guests that are here, our speakers today, from the chat room, and focus it through using the Slido technology that will be guiding you around shortly. Well, friends, today's theme is working towards a net zero emissions, climate resilient, equitable and environmental sustainable healthcare sector, ensuring good health is for all. It's a pretty ambitious theme, isn't it? But when I look at those of us that are going to be speaking into this opportunity that we have today, I think we're going to be led incredibly well, challenged and invigorated to be called to action around what our response might be in that space. Our speakers today will cover the why and the how and what we can actually do about it. And I'm really conscious that in my space at Uniting Care, our why is because we recognise that the health and well-being of our residents, our patients, our clients and our staff is inextricably linked to the health of our planet. We recognise that our mission is to actually improve the health and well-being of individuals, families and communities, and it must extend beyond the front line of our service in a very holistic way. If you're wondering what a definition of a forum is, it's simply an opportunity for us to exchange ideas and discuss things together. And we want to create an environment where it's okay for you to do that and really interact in a positive way. Well, who's here today? I believe we have the latest call, and the numbers still keep rolling forward around this, but I believe we have 296 participants in our community, both here face-to-face and also online. And if you have a look at this latest update of forum participants, you can see a bit of a result there. Queensland's at the top of the list there, 164, but let me not just barrack that. I'm supposed to facilitate and guide you and mediate, but a little call out for Queensland. That was certainly the head of the post there. We've got a very diverse, as you will see, response there in terms of who's being represented today, both in healthcare, in aged care, universities, supply chains, industry partners, government departments, students, and advocacy organisations. So we're in for a really rich community as we might think in this space together. Well, I've already indicated that we are using Slido as our platform for you to get the mind, I guess, of the participants, but also for you to raise questions. And as this is a hybrid event, it's really important that using the Slido app that we're about to use will help ensure that every person who's a participant here has an opportunity to interact and participate in this way. So let's take a moment to introduce you to Slido. I don't know if you're familiar with this platform before, but there's a couple of ways in which you can access Slido. You can simply put in the web address of slido.com, and in that you can enter hashtag Green Health Forum 21 and use that as your reference. Or if you want to, you can simply use this QR code that's found on the screen now, and that will guide you directly to there as well. Throughout the day, there'll be an opportunity for each panel with a Q&A session, and you can use Slido to actually ask questions there. And once we're up and running, you'll also see questions that others have asked, and it will start to build as we go on. Well, just for a little bit of fun, let's have a play with Slido for a moment. And I want to ask a question. So here's a chance for you to go there and name what is the number one reason that you decided to join this forum today. So let's have a go. Let's see the energy start to mount. You'll see it live unfolding before us on the screen or on your screen, wherever you're situated throughout this country. And those of you that also participate abroad, it's so good to have you, and I hope that you can also interact in this way. So you can already see it's starting to build there, knowledge building. We're up 23% of, I'm looking for new inspiration and ideas. Some people here just to network. You know those people, they're continually trying to rub shoulders with you and getting energized just by connecting with you, whether that's online or whether that's, and we have to do it differently these days, don't we, online. And the speaker lineup obviously is really important, but the number one thing that is really hitting our commentary at the moment, and the most energy is around knowledge building. Well, friends, we're going to pause for a moment and want to introduce you to Tommy, who's going to lead us in a welcome to country. So thanks. Tommy is one of our First Nations peoples who identifies as being a traditional owner of the land in which we meet today. And welcome, Tommy, and I ask that you might lead us in that way. Thank you so much.
Yera yera, hello and welcome. For those who don't know me, my name is Bundamba Ya. I'm also known as Thomas of the Coggill family and Thomas of the Bonner family. The name Bundamba Ya is a traditional name that was given to me that I earned from the Yagara, Jagara, Yugrupu elders of Brisbane and Ipswich. I'm a Yagara descendant or descendant of the Yagara language speaking nation through two tribes or two family lineages. Through my father's side, I descend through the Bonners. Grandfather Neville Bonner is my direct great grandfather. He's a Jagara man, and his he descends from an ancestor by the name of Maltagra. Maltagra led the battle against Captain Logan out there recorded at Tabletop Mountain, just at the foothills of Toowoomba and Warwick. When Dad speaks about Granddad, he said that Granddad was born on a traditional birthing spot, an island just off the Tweed River. His mother was dispersed from the Deben Creek area, and they had to trek down to the Tweed River for that birthing spot to give birth to grandfather Neville Bonner. Granddad also was a very hard worker, and the word yaka, the phrase that we have, hard yaka, yaka is actually a Yagara Jagara word, which means strenuous work. So apply hard to it, just means hard, strenuous work, which was the work ethic of those people in that era. On my mother's side, I descend through the Mortons. The Mortons' patriarchal ancestor, or we can trace it back to on paper, is Grandfather Mookin. Grandfather Mookin, his era was in the 1880s, early 1920s is when he was recorded. He was recorded with a traditional name, Mookin. His name was changed later to Charlie of Morton and then Charlie Morton. In the Brisbane area, prior to the 1920s, this area was considered Morton. Grandfather Mookin was actually selected to be the last message stick carrier for the region, for the Yagara language speaking nation. For those who don't know what a message stick carrier is, it's a very important role that every tribe has, or every language speaking nation has, and it's to do with having festivals and asking for permission to travel into somebody else's country. In this area, we had a lot of festivals, but two festivals still remain, which is the Bunyanut Festival held in the Woodford Valley, or the Bunyanut, the Glasshouse Mountains, and also the Undercull Festival, which is located on Minjiri Bar, which is North Stradbroke Island. And what would happen was these festivals will occur and would be in separate, different clans and different tribes would be invited to these areas. When they were invited, they have to first send forth their message stick carrier to ask for permission. Granted permission, they will bring their tribe with them. They'll do a welcome to country ceremony, immediately followed by the smoking ceremony, which we call Chumodalo. And the Chumodalo is to smoke the area and cleanse it for negative spirits, or what we call mugai, bad spirit. And it leaves room open for the good spirit to come in and enjoy the festival. Yagara country, it extends from the mouth of the Brisbane River, also known to us as Maiawa. You follow that, it has two central locations of gathering points. On the south banks of that river is Kurilpa. Kurilpa means place of the water rat, and it essentially goes from the Kangaroo Point Cliffs all the way down to Davies Park, West End. Our second location is, Meanjin. Meanjin means the spike of the spear, and its location is where Botanical Gardens and Parliament House sit today. You follow the Brisbane River all the way down to Ipswich, or Maiawa, all the way down to Ipswich, and then the plains to the foothills of Toowoomba and Warwick. That's our western border. Our southern borders is the Logan River, which runs through Bow Desert, parts of Logan. Logan's Aboriginal or traditional name is Birrambah. It means dwelling place of the south. You follow the Logan River all the way out to Moreton Bay. In our language, we call it Quandamooka. That means dolphin storm. And there's a Dreamtime story that's attached to that area that developed that area. When we talk about Dreamtime, we talk about the creation. Our northern borders is the Caboolture River, Kabul meaning carpet snake and Cha meaning belonging to. We have a Turrbal and Dumbi connection. On the other side of that Caboolture River is another language speaking nation. Our eastern borders is the bay itself, Moreton Bay. It's overlapping due to the language and the landscape that is there. Also saying that, Yagara with the Turrbal and Dumbi connection would like to acknowledge our neighboring language speaking nations. To the east, the Quandamooka or the Jandai language speaking nation. To the north, the Kabi Kabi or Gubbi Gubbi. To the west, the Waka Waka. To the south is the Yugumbe. Also saying that Yagara with the Turrbal and Dumbi would like to acknowledge the Torres Strait Islander community here living on Jarrah, and also the South Sea Islander here living on Jarrah. In the words of the old tongue, I'd like to welcome you on behalf of the Yagara language speaking nation, and say Yira Yira, Nambale Ganare Bajara, Nania Yagara Nuro, which means hello and welcome. I welcome you and also the good Nuro, the good spirit. I'm gonna play a little bit of this instrument here. It's called Didgeridoo. To the Yagara people and surrounding clans, we call this instrument Brida Mandu. Traditionally, it comes from the Yurukala people, which is located up in the Darwin area, Northern Territory. and it came along the coastlines, and we traded the fire sticks, which we call Jarlo or Buri in North Queensland. We traded the fire sticks. What came down with it was the didgeridoo or Brida Mandu and its law. The law of the didgeridoo is this is strictly a men's instrument and men's instrument only. Women are forbidden to play this instrument, and they're also forbidden to touch this instrument. Also saying that women have their own instrument, which is a gumpy skin drum that they stretch over their legs and beat to the rhythm of the song and dance, and men are forbidden to play that instrument or even touch it. Ladies and gentlemen, didgeridoo, or in my language, we call it Brida Amandu. Thank you. I'd also like to give a warm extended welcome to those who are joining us here online. Also, on behalf of the Yagara language speaking nations and also my family lineages, my tribes, the Mortons and the Bonners through tribal experiences, I'd like to thank you for inviting me out here to do the welcome to country, something that's traditional to our practices. And I'd like to thank you for letting me come here and share some of my culture with you. Yerda, yerda, welcome. Thank you.
Well, Tommy, we do thank you for that incredible welcome that you've given to us. I don't know about you, it just feels like we've begun on a really special, sacred space, if you like, as we've been invited into this space through Yagara people for this forum that we're sharing in today. So whether you find yourself as part of our online community today, please know that you're most welcome in the midst of this. One of the housekeeping things that I failed to mention to you, I've been told that the masks that we need to wear whilst in the facility, whilst you remain seated, you're able to take your masks off, and that's okay. But as soon as you get up and move around, you'll need to reinstall those masks back on your face to keep us in our COVID safe environment. Look, friends, it gives me great pleasure to introduce you to our first speaker today, Dr. Nick Watts. Dr. Nick Watts is the Chief Sustainability Officer of the National Health Service in UK, and Nick will be joining us online as part of his input today. He's responsible for its commitment to deliver a world-class net zero emission health service. Nick leads the greener NHS team across the country, which focuses on improving health and patients and the public through a robust and accelerated response to climate change and the broader sustainability agenda. Nick's a medical doctor, has trained in population health and public policy. And prior to the NHS, Nick worked as the Executive Director of Lancet Countdown and the Lancet Commission on Health and Climate Change. He has also focused on engaging the health profession on links between public health and climate change, having founded both the Global Climate Health Alliance and the UK Health Alliance on Climate Change. Would you join with me in welcoming Nick to present to us today? Thanks.
Hi, hello. You can hear me? Carol, I can see your face. Not if you can hear me. Fantastic. It is so nice to be with you early this morning. It is so nice to be with you in a place where I don't have to apologize for the fact that no one can understand my accent. It's so nice to not have to apologize for the way that data is supposed to be pronounced. It's so nice to be here talking about the biggest global health threat of the 21st century. So, my name's Nick. I'm from Perth. I'm here in London. For anyone that's from Perth, those are the blueprints of the Hotel Albion, my favorite pub from Perth, just down the road from where I grew up. I'm here and you guys have a really exciting day ahead of you. So I am going to be as brief as I possibly can as we kick this off. I'm going to talk about three things. Why, what, and how. Why the NHS might care about this, what on earth the NHS thinks it is going to do about it, and most importantly, where we need to spend all of our effort and time thinking and working, how, what tomorrow morning are we all going to get up and do about this? So the NHS, we're very proud over here, you can imagine, world's first health system with universal health coverage, founded with a pretty exciting principle: high quality care for all, now and for future generations. 80, 90 years, that's what the NHS has been about. It's on every bit of letterhead we send out to every single patient: high quality care for all, now and for future generations. So to answer the question of why would the NHS care about climate change? It's very, very simple. You cannot achieve that goal unless you respond to climate change. You can't do it. Here in the United Kingdom, in fact, globally already today, I checked this morning, I do it every now and then when I want to depress myself, global average surface temperature, 1.17 degrees above pre-industrial average. Temperatures rising at a pretty significant scale. How much energy into the system? Well, very, very roughly the equivalent of 6 atomic bombs worth of additional energy released into the planetary system, into the atmosphere, every single second of every single day, of every single month, of every single year for decades and decades, resulting in that 1.17 degrees rise for the NHS. We expect within the next 9 years, resulting in the doubling of the number of our facilities across the country that are in high-risk flood zones, resulting in a tripling of the standard deviation of the heat waves that we have to deal with, that our patients have to deal with, that our staff have to deal with, that our facilities, and listen, here up in the United Kingdom, we're not equipped for that kind of heat that they have to deal with. For the first time, a year and a half ago, 18 months ago, Public Health England found an endemic Aedes aegypti case. Wasn't carrying anything dangerous, but it was the first time in 50 years that we found that up here. And we know from past experience, not Aedes obviously, but malaria previously found throughout Germany, and we know many of the slightly more dangerous things that Aedes can carry, previously found and currently marching up through Europe. The NHS can't exist, can't continue to do the work that we do, high quality care for all now and for future generations, unless you respond to climate change. That's the first reason why. The second reason why is because, hey, we're part of the damn problem. We are big, 1.4 million health professionals scattered across the country, the 5th largest company, the 5th largest organization in the world, responsible for 5%, just under 5% of national emissions, The total emissions of the NHS, roughly the same size as the entire country of Denmark, the entire country of Croatia. We are 40% of public sector electricity consumption. We are 36% of public sector emissions. We're a part of this problem, and all 1.4 million of those health professionals signed, spoke, pledged some kind of oath when they started. First, do no harm, primum non nocere. It's the second reason why the NHS cares about this, because we know that we're part of the problem, and so we need to be part of the solution. The third reason why the NHS cares, and this is the really important one, right? Number one is impact. That's scary. Number two, part of the problem, we want to do something about it. Number three, though, this energizes our staff. Every single year we go out and we ask NHS employees, 1.4 million of us, hey, what do you care about? What do you want to see the NHS do more of? What really gets you up in the morning? Every single year, staff shout back at us. They demand, we want to drive forward the NHS's response to climate change. Now, I was quite worried that in 2021, we could be forgiven if there were other things on the mind. It's been a busy year. There's been a lot going on. I was anxious about asking that question again because it might give you an inconvenient answer. I was wrong to be anxious. 2 percentage points higher. 92% of staff shouted back, even in 2021, I want to see the NHS respond to climate change. I want to work for an organization that is aligned to my personal values. That's the why. That's my version of the why. If you are here already in the morning on Tuesday, sometime in December, November still for you guys and for me, you don't need to know the why, but that's our version of the why. Planetary scale crisis. So what are you going to do in response to that? The NHS has cared about this issue for a long time, 10 years. We're proud of our track record. The NHS is proud of its track record. Just last year, 2020, there was a step up, not just of 1 or 2 gears, but an order of magnitude in the response to climate change. We went from what was previously a small team, 4 or 5 people, working on starting to envisage, starting to sketch out what a solution might look like, to a team now, to an army, a small army of 140 health professionals dedicated to greening, to transitioning the NHS to a net zero healthcare system. And that's the important part of the what. For the emissions we control directly, net zero by 2040. For the entire footprint, not just within the United Kingdom, not just within the 4 walls of our health system, but our entire global supply chain footprint, 2045. We're taking responsibility for that, despite the fact that we know that that's going to be particularly tough. And that's where the real magic of a target like that is in that full footprint. And if someone isn't making commitments like that, then I promise you they are ducking the hard questions. 2040 and 2045 are a long way away. And so you need something closer that is going to make people feel uncomfortable. 2028, we want to see an 80% emissions reduction target. We're going to have a really steep decline, and then we're going to bottom off because we have a last mile problem. The last 10%, 20% or so is really tricky just because of some of the nuances in how healthcare runs, because of some of the physical infrastructure we own. That's the why. That's the what. Where I said and where I think we should spend our time thinking about. We don't need to talk about why. We don't need to talk about whether or not we should be responding like this anymore. The time for that was decades ago. The only real discussion now should be tomorrow morning, how? What are you going to go and do about it? Not what are you going to go and do in 2040, not 2028, but tomorrow morning, what can you wake up, do to reduce your emissions? And so we report annually now. We report publicly and annually because we want to hold our own feet to the fire on our emissions reduction. 12 months ago, when the NHS became the world's first health system to make that commitment, we said, hey, our annual emissions reduction that we need to achieve, 1,260 kilotons of carbon. 1,260 kilotons equivalent of carbon. Roughly, to put it in context, it's a bit meaningless without that, 1.7 million flights from London to New York, 1.1 million homes powered throughout the year up in cold Yorkshire, where God, you need some heat. That's what we were aiming for. So we've had 12 months. What have we done? Let's break the emissions profile of the NHS down and talk through each piece. So the estate is a big part of our emissions profile. Depending on how you cut it up, somewhere between 12 and 20%. Couple of things. Number one, we've invested. We've invested heavily, £310 million in year one, £500 million in year two, coming up just around the corner. We've invested heavily in climate smart healthcare, in more efficient healthcare, in digital first healthcare, trying to make sure that the care that the NHS is providing is world class, trying to make sure that it's more comfortable for our patients. The real secret of a lot of this, though, is it pays back so quickly. The investment in a net zero capital estate, it pays back in 3.5 years. It's got some of the best ROI you can imagine. And the reason we have ROI like that is because, God, we're just talking about efficiency. We're just talking about doing excellent healthcare just a little better. So we've invested in that and we're already starting to see the benefits. It's looked like anything from transitioning and decarbonizing the way that we heat our buildings, solar panels on roofs. It's looked like electric chargers scattered across the system, electric vehicles. It's been a really exciting 12 months for the estate. That's the existing estate, though. We also have a commitment to build 40 new hospitals. The number varies a little depending on how you count the hospital, but 40 new hospitals. Each of those things, I promise you, they've got to be net zero if you want to get there by 2040, 2045. And so we have a new hospital standard. It's not ready right now, but we have one of our, I'm hoping, final meetings with the minister in a couple of days to finalize this. A new standard for all hospitals, all new hospitals built in this country, meeting that net zero standard. Now, if someone tells you, hey, I can build a net zero hospital today, they're lying to you. Technology isn't quite there. They're probably offsetting far more than we should allow. So what this standard does is it takes the best available. It takes the long-term cost profile and allows us to reinvest some of that savings accrued up early and up front. And then it has a process for continuously improving. There's a process for, thanks, Carol. There's a process for shifting as technology increases over time. I reckon about 4 years from now, we will be able to say, hey, we're on our way to building the world's first net zero hospital. That's the estates world. That's the fixed assets. You've got to get patients to and from those assets as well. And so in the transport world, we're looking very seriously at electrifying the fleet. We're not just looking seriously at it, I shouldn't say it that way. We've shifted our contracts. Give us 8 years and we are going to start only contracting with suppliers that are able to provide fully zero emission vehicles. That stuff's going to be easy. Some of the harder stuff is the specialist vehicles, the rapid response vehicles, the ambulances. There again, we're really proud. In the last 12 months, we've put a lot of investment into innovation. Previously, a couple of weeks ago, there were no zero emission ambulances in the world. Now there are 2. One of them fully electric, carrying patients right now in Birmingham. The patients love it. It is quiet, it is more comfortable. The air pollution is less. The other one, an electric hydrogen hybrid. It can go 300 miles on a single refuel. It can cover all of our rural populations. Estates, transport, we have new incentives into medicine, switching away from some of the most polluting anesthetic gases, switching away from some of the most polluting inhalers, switching away from some of the outdated forms of gaseous analgesia, shifting to better quality medicine, but accelerating that transition because we know it's good for our patients. It's also good for our response to climate change. Estates, transport, medicines, procurement. The NHS buys a lot of stuff, 80,000 suppliers, £60 billion worth of spend every single year. We have been very clear. Beginning January 1st next year, every single tender will have a 10% weighting for carbon for net zero built in. April 2023, all contracts over £5 million. If you want to do business with the NHS, you have to demonstrate that you are aligned with our principles and aligned with our trajectory on net zero. 1 minute past midnight, April 1st, 2027, every single contract, full stop. If you aren't aligned with the NHS's trajectory towards net zero, we're very sorry, we're not interested in doing business. We want to make sure that we are doing business with companies, with parts of the economy that are aligned with our principles, with our values, and we know that this is the direction to travel. So look, that's the why, that's the how, that's the what, and that's the how. It's been 12 months. The work in the estates, transport medicines, the work of tireless nurses, pharmacists, physiotherapists, setting up new sustainability innovation projects, new ways of interpreting our net zero strategy down to the trust level. There's not just one strategy anymore. There are 220. Every single trust has a net zero strategy now. That work over the last 12 months is what's got us to the point where we are really proud, cautiously proud, to be able to say that we hit our first year emissions reductions targets. Proud because it's important that we start to move away from talking and we start to move towards doing, that we start to do. Cautiously proud because the next year and the year after that and the year after that is going to get harder. We've hit a lot of low-hanging fruit, and so we're going to have to start tackling some really tough stuff. I'm going to finish with the reason that we're cautiously optimistic. 12 months ago, the NHS was the only healthcare system, the only national healthcare system in the world, 1.4 million healthcare professionals, 120 billion pounds worth of turnover. The only one with a net zero target. Just a week or three ago, up in Glasgow, a really special moment happened. Not everyone saw it. The world went from 1 to 14 healthcare systems around the world. Some of them doing impressive stuff back home in Indonesia, in Malawi, and Fiji. Some of them big healthcare systems, Spain, Benelux. And a couple more, I promise you, watch very closely what Germany has to say over the next 3 weeks. Watch very closely what the United States has to say over the next 2 weeks. A couple more on the way. The reason I'm cautiously optimistic is I know that we have hit some low-hanging fruit and this is going to get harder, but I also know that the NHS is no longer alone. I also know that this is no longer just something that is possible, that is interesting. Oh, that's nice. The NHS has started to think about this. It's no longer something that is just positive and it's sort of, nice to have, despite the fact that, surely we have other priorities within a healthcare system. In the middle of a global pandemic, transitioning to a net zero healthcare system has not just become something that was possible or positive, it has become something that is inevitable. This is the direction of travel for the world's healthcare systems. The question has now changed from what are you doing on climate change to why on earth are you not charging ahead? Why are you not at full speed transitioning? You're going to get left behind. I'll stop there. Thank you very, very, very much for having me. I'm so sorry I couldn't be there in person.
Issues out there in the back horizon, and our next speaker was Dr. Janine Mohammed, but we're actually going to move a little bit further down the list. Janine's been cut offline for a moment and we've lost contact with her. So we're going to now introduce you to Dr. Kate Charlesworth, who is online waiting to participate with us today. Dr. Kate Charlesworth is the public health physician in Sydney. And after working as a hospital doctor in Australia, Kate completed much of her public health medicine training in the UK. She was a research fellow at the London School of Hygiene and Tropical Medicine, and then worked in the NHS's National Sustainability Unit, the leading healthcare decarbonisation program in the world. Kate also has a PhD in low carbon healthcare and now works as a medical specialist in climate risk across Sydney North Primary Health Network and Northern Sydney Local Health District, the first such role in Australia. Please, would you join with me in welcoming Kate to speak to us right now? Thanks, Kate.
Thanks, everyone. Can I just have a sound check or a thumbs up that you can hear me? Yeah, great. Terrific. Thanks, Carol. So thanks so much for the invitation. Really delighted to join you today. I would just like to, sorry, just trying to advance my slides. Great. I would just like to add my acknowledgement of country. I'm on Camaragal land today, and to note that Aboriginal people have been tremendous stewards of this land for more than 60,000 years, and that these themes of stewardship and care of country are particularly relevant to what we'll be talking about today. So I have three key messages for my talk today. The first one is that I think that a lot of people, a lot of health professionals think that climate change is important, but few of our colleagues realise how urgent and how serious it is. And it's now the case that delay is as dangerous as denial. And secondly, if we take a big picture view, and Nick has talked to this somewhat, if you look at this, we really have two key tasks ahead of the health system. Okay? We need to get to net zero. We need to mitigate. We need to stop being part of the problem, as Nick mentioned. But we're also going to need to be climate resilient. Even if we stop polluting tomorrow, there are climate changes locked into the system, and we need to be, as a system, prepared and resilient for those. So I'll be talking today about sort of what we're doing on those two areas. Okay. So over the past few months, there have been a number of scientific reports published, obviously in the lead up to COP26, setting out the urgency and the seriousness of the situation, with the UN Secretary General describing this now as a code red for humanity. And in this case, the really important point is the urgency. We have now left this so late. We have ignored scientists' warnings for decades that we now need really decisive action to avoid catastrophic climate breakdown. Okay? As you can see in that headline there, the modelling suggests that in Australia, we need to get to net zero by about 2035, with most of that achieved by 2030, okay, to avoid catastrophic climate breakdown. So as in that headline there, we've got 10 years, basically got 10 years now to fix this. And of course, the climate crisis is not just an environmental crisis, it's a health crisis. Okay? And Australia is one of the countries on the front lines of climate health impacts. Okay? So as a system, we will need to be prepared for extreme heat, for bushfires, for storms, floods, droughts, for rising rates in allergens, shifts in infectious diseases, mental health impacts, and so on. And not just the impacts on our patients and our communities, but also thinking about the impacts on our workforce, our infrastructure, and indeed our supply chains. Okay? So that is an enormous task. And whilst there's a whole range of things to be prepared for most metropolitan populations in Australia, the number one climate health impact is extreme heat. Okay? The health professionals and systems will need to work alongside urban designers, transport, community groups, councils, and so on in preparing for extreme heat, and in particular for protecting the most vulnerable in society. So we have a big task ahead of us in terms of adaptation and resilience. But as Nick has said, there's also another equally important task to this, okay? And that is to reduce our own impact. We use huge amounts of resources, we use huge amounts of plastics, produce vast amounts of waste, we use fossil fuel based energy, we have a big carbon footprint. And so the irony is, this is the health system, which is supposed to look after people, is in fact a major source of pollution. It's contributing to the climate crisis, which is harming human health. Okay? And that is completely inconsistent with our core business and completely inconsistent with the values of most health professionals. Okay? And so if you pull all that together, you think we have experienced disruption over the past 2 years. It's just a warm up for what is to come. Okay, so then the key point, we have two key tasks. Mitigate, we need to get to net zero. Every sector, transport, energy, education, everyone's going to have to get to net zero. We have a particular responsibility and indeed opportunity to do that. Okay? And also adaptation, resilience. I'm going to talk more about mitigation today, but these two key tasks are equally important. And indeed, as you can see in that diagram there is a lot of overlap between the two. Okay, so net zero, how do you get to a net zero health system? If you're going to do that, the first thing you need to do is understand your carbon footprint. We have done this research in New South Wales and indeed in Australia, but this is the NHS's carbon footprint. This is the most up-to-date and comprehensive analysis that I've seen. Okay? So you can see in the green section is travel, so there's patient, staff and visitor travel. It's about 10% of our footprint. Okay? The red section is about the direct delivery of care. So you can see there the usual suspects: fleet and business travel, water and waste, and building energy, but also anaesthetic gases and MDIs, metered dose inhalers. There are specific carbon hotspots that we're going to have to look at. And then, of course, the key point is the big blue section, the supply chain. More than 60% of our carbon footprint is the stuff that we buy and use every day. It's pharmaceuticals and chemicals, medical devices, equipment, right down to food and furniture. So if we're going to get to a net zero health system, we're going to need to tackle all of these things. So what are we doing? In Northern Sydney Local Health District, where I work, we now have a board approved target of net zero by 2035. We have a Planetary Health Committee, which is chaired by our Chief Executive and which has a number of members of our senior leadership team. Okay? And we have a Planetary Health Framework. You can see there with those 5 priority domains. And basically, we sort of carved up the tasks. So our Director of Capital Works, who's a very keen engineer, is the Planetary Health lead on buildings and energy. Okay? Our Director of Health Promotion is the lead on people and places. So that's looking at greening our campuses and active transport and so on. And I'm most involved in models of care, which of course impacts on procurement and also on waste as well. And in models of care, we're in the process of setting up net zero teams. Okay? So eventually we're going to have net zero teams in every service, in every specialty, but we're starting with respiratory and anaesthetics because they're 2 big carbon hotspots. Okay? So net zero team is comprised of a multidisciplinary team, so nurses, doctors, allied health professionals, pharmacists, whatever, at all different levels of seniority, so from consultants down to students. Small team, probably 10 or 15 people, partnered up with researchers, and the task of that team is, okay, net zero anaesthetics by 2035, and all the projects need to be aligned with that. That's our task. I'd just like to note that my role, of course, is across primary care and tertiary care. The Sydney North Health Network, the primary health network in our region, is the first in the country to have a climate and health strategy. So it's a terrific partnership between our 2 organisations in this key role. Okay, so a couple of slides. We need to do energy. This is Hornsby Ku-ring-gai Hospital. It's one of our solar projects. We also have one at Mona Vale Hospital. Clearly we need to do a lot more. This is a good starting point, but there's a lot more to do. And this is the sort of direction in which we need to head. This is the new Women's and Children's Hospital in Adelaide. We're the first 100% all electric hospital in the country with no gas, actually. And then on transport, again, we need electric vehicles in our fleets. We need charging stations. We need electric sort of public transport, but also this focus on the co-benefits, things that have health and environmental benefits. And walking and cycling is a key one. Physical activity, of course, has a whole range of health benefits. So these are win-win situations. Okay, so then to models of care. So in our net zero teams, these are the 4 key principles that will guide their approach. And this is from the CSH in Oxford, the 4 principles of sustainable healthcare. Okay? And the first one is prevention. And that's because one type of carbon neutral system would be a system in which we didn't have any patients. Okay? Everyone was healthy and well and independent in their homes and in their communities. Okay? The second one is patient self-care. So that's about more informed and engaged patients, and also in other models, peer-to-peer models, link workers, compassionate communities, social prescribing, that sort of thing falls into that. So 1 and 2, keep people healthy and well and independent. The third principle is about minimising wasteful activities. And that's not just rubbish bin waste, that's clinical waste. So we know that overdiagnosis and overtreatment has significant harms and risks for patients, and also costs. Those costs are not just financial, but also carbon costs. Okay? The next step we need to do is reduce unnecessary overdiagnosis and overtreat. And then the final principle is, okay, where we do have effective evidence-based care, how do we decarbonise that? How do we choose the lowest carbon alternative? Okay? So these are the 4 principles that will be guiding our net zero teams in their approach. Okay? And this is a paper that we published a couple of weeks ago in the Medical Journal of Australia. And it takes there, on the left, the pie chart there is the Australian health system's carbon footprint. Okay, so you can see it's divided up such that building it in electricity, gas overall is about 20%, but clinical care is the majority, it's about 80%. Okay? And then you take that 80%, shift it to the right. We know that from Wiser Healthcare's work and from the literature that 10% of clinical care is harmful care. Okay? That is, a patient goes for an unnecessary test or an unnecessary procedure, and they actually have a bad outcome from that. That is harmful care. The 10% is harmful care. 30% is low value care. That's overdiagnosis and overtreatment. So as you can see there, we are currently wasting more than 10 million tonnes of CO2e, carbon dioxide equivalent, on harmful or low value care. Okay? So we need to quickly reduce that. And then you can see this in practice now. So a lot of Wiser Healthcare has fed into things like the Choosing Wisely recommendations. So in this example, the Australasian College of Emergency Medicine has put together 5 or 6 recommendations, about evidence-based care and things not to do. So you can see there, those that, the do not do lists are displayed there in some Queensland emergency departments to remind clinicians about them. So this is a sustainability initiative. And then just telehealth, to mention that we need to think about innovative ways of delivering healthcare. In our district last year, we saved more than 500,000 kilometres of car journeys, which is more than 100,000 kilograms of greenhouse gases by using telehealth. So telehealth is going to be most likely an important part of our net zero shift. And then on to carbon costing. Okay? So in the future, carbon will be as important as money. It will be like a whole new currency. And health professionals, and they have to understand carbon cost of different investigations and procedures. So this is a paper published in the MJA last year. It showed for the first time the carbon footprint of the 5 most common hospital pathology tests. There is now literature on everything from the carbon cost of cataract surgery to the carbon cost of different forms of childbirth, to the carbon cost of different reflux treatments. Okay? This increasingly is going to be an important evidence base for clinicians to incorporate into their decision making. And then, as I mentioned, there's some specific carbon hotspots, and these are the things we're looking to tackle first. So the propellants used as, the hydrofluorocarbons used as propellants in meter-dose inhalers are very potent greenhouse gases. Okay? There are the disc type dry powder inhalers are much less environmentally damaging. So this is an area that our respiratory team is going to be looking at. And anaesthetic gases are 5% of the hospital's carbon footprint. Okay? So this is something our anaesthetists are looking at, shifting gases, switching to TIVA, which is intravenous anaesthesia where appropriate, and of course looking at plastics in theatre. Which brings me on to this point. We know that waste is a major concern to many of our staff and also to our community. We need to be looking at reducing the use of single-use plastics, but there will be some unavoidable plastics and we need better solutions for those. So in this example, this is St Vincent's Hospital in Sydney. They're recycling water and saline ampules and needle caps into new products. So you can see at the bottom there, the roller doors and pipes for plumbing and so on. Okay. So we're looking at a few different options at the moment with a view to starting a pilot next year. So these circular economy initiatives, these plastic recovery initiatives will be an important part of our program. And then this is sort of the final point, but a very important one. There are so many co-benefits in this space. Right? In health services, low carbon health services are very well aligned with more accessible, more innovative, more patient-centered care, and with reducing harms and risks to patients. And of course, more broadly, so many climate actions will have significant benefits for health. Will mean cleaner air, healthier diets, greener and cooler cities, more connected communities, and so on. So this is a very good and very important story. And who's best placed to tell that story? This is Ipsos Mori. It's a social research institute in the UK. And every year they rank from the most at the top down to the bottom, the least, most trusted professional groups in society. So you can see doctors do pretty well, 91%, but nurses are the winners. So health professionals are the most trusted and respected professional group in society. We have a huge amount of influence in our workplaces, in our professional organisations, but also in our communities and with the media. And the climate crisis threatens our patients, our communities, and indeed our own families. And this is happening on our watch. So we have a big task ahead of us. We need to develop a low carbon, climate resilient health system, and we need to advocate for climate actions much more broadly as a health measure. And we have 10 years to do it. So we're going to need all hands on deck. Thank you.
I want to thank you, Kate, for that incredibly inspiring challenge that you've given us all. I love that frame that you just finished with, saying that action feels better than anxiety. And, you know, I think we've all been incredibly challenged around, you know, folks, we're in code red, like we cannot but do something right now. And you've called us to take very different action, both in our service delivery. The other thing I was really incredibly challenged around is the percentage of contribution that actually 80% comes from our clinical care. And that was one thing that really spoke loudly to me. I know about you. So thanks so much, Kate, and we've already thanked you for leading that. We're going to engage with you a little bit later on, just in a Q&A. So friends, it's a bit of a call out. Keep those questions coming through Slido as our forum, and to be able to engage with you shortly through a Q&A around that. Don't be tempted to put it in the chat room, put it through Slido, because we can gather your thoughts there and work out what are the most pressing questions that we want to engage in together as a community. Well, I'm going to introduce you now to Dr. Janine Mohammed. Dr. Janine is a proud Narungga Ghana woman from South Australia. For over 2 decades, she's been working in nursing management, project management, research, workforce and health policy in Aboriginal and Torres Strait Islander health sector, including as CEO at the Congress of the Aboriginal and Torres Strait Islander Nurses and Midwives. Janine is currently the CEO of Lawidja Institute at Australia's National Institute for the Aboriginal and Torres Strait Islander Health Research. Janine is a regular spokesperson on Aboriginal and Torres Strait Islander health issues, including racism, cultural safety, climate change, and social determinants of health, workforce, and Indigenous data sovereignty. Would you join with me in welcoming Janine to this forum? In doing that, I've been advised that we've still lost a formal connection with Janine online. So we have in our situ a prepared video from Janine, and she's going to speak into us through that medium now. But let's continue to welcome her anyway to the stage in this way as we engage with her now through this medium.
Thank you and good morning, everyone. I'd like to begin by paying my respects to the Turrbal and Jagera peoples on whose land this conference is of course being held. I would also like to acknowledge the Dja Dja Wurrung peoples on whose land I'm fortunate to live and work on, and pay my respects to elders past, present and to future emerging generations for whom our collective work is so important, and to acknowledge the long history of our people's sophisticated holistic knowledge systems that have informed our historic and ongoing roles as custodians caring for country. I am a proud Narungga Ghana woman and the CEO of the Lowitja Institute, Australia's National Institute for Aboriginal and Torres Strait Islander Community-Controlled Health Research. Can I say how pleased I am to come together with a group like yourselves, people whom are committed to working towards, net zero emissions, climate resilience, and an equitable and an environmentally sustainable healthcare sector that is ensuring good health for all. That tells me that you are committed to doing the hard work that is involved in changing entrenched systems that normalise inequity. It tells me that you have some sense of what it means to be doing the work and the hard work to transform dominant culture. Those challenges are something I know only too well through my work to embed cultural safety across the health system and to impact racism. And it tells me that you understand the importance of the holistic understandings of health, and that our health and well-being are directly related to the health of a country. This is something that my people have known for tens of thousands of years, and that contemporary health sector is now, getting up to speed with, beginning to grasp through concepts such as environmental determinants of health and planetary health. So today I'd like to speak to you about some of the much needed research we've taken or undertaken on climate change and our health. And this could not have been achieved without the Climate and Health Alliance, who have been fantastic allies for us in doing this work. They helped us navigate systems and open doors for us that otherwise might not have been opened, and of course that we benefited from, like being able to participate in the side event at COP26. And I encourage you that if you're working for a more sustainable and equitable healthcare sector, that you take some lessons, a feather out of the cap from the allyship that we've experienced with CAHA. This slide shows you our climate change and Aboriginal and Torres Strait Islander health discussion paper. It was prepared for the Lowitja Institute and the National Health Leadership Forum by the HEAL Network, the CRE STRIDE, CAHA, and we particularly want to thank Dr. Veronica Matthews for leading this work for us. You can find the report at that Lowitja Institute site address there on the slide. Please download it, read it, and share it with your colleagues and networks. Include it in your newspapers, feature it in your journal clubs, and I encourage people to engage deeply with its messages and its calls to action. I was really very proud to officially launch our report at the side event meeting that I aforementioned at COP26. Following its, pre-discussions at a virtual roundtable meeting just last month, and you can see the tweets from that from the side event there on the slide. We've seen incredible leadership shown by many Indigenous peoples globally through their activism and their contributions to COP26. It was also fantastic, awesome, deadly to see many young Indigenous peoples advocating in Glasgow. And it reminded me personally of a wonderful quote from the 2021 Close the Gap report, which Lowitja Institute wrote and can also be found on our website. It covered the exceptional legacy and leadership roles of Indigenous people in the face of multiple crises, including the growing toll of climate change. The quote that really does stick out in my mind is from the Seed Mob Youth Climate Movement, who declared in our report, all around the world, sea levels are rising, and so are First Nations people. For the Lowitja Institute, our journey to this contribution to climate action began in developing our strategic plan, acknowledging that climate change was a policy area that absolutely needed immediate attention when it came to the health and well-being of our peoples. The report highlights the disproportionate effects of the climate crisis upon our people. We heard from them directly at our roundtable last month when we heard from an elder from Tennant Creek in Central Australia, Mr. Norman Japaruwala, who described how extreme heat was affecting the health and well-being of himself, his community, and of course, his country. He told us that when he went away for dialysis, which is obviously he did on a regular basis, he returned to find his power off because of extreme heat. His food was spoilt, and it was a long way to go and get food. And of course, food is very expensive in this region, and his medicines were unable to be kept cool and safe. And so therefore they're unusable. And of course, in some instances, that's life-threatening. The Journal of Pediatrics and Child Health has recently published an article by himself and his non-Indigenous Dr. Simon Quilty, which addresses many ways that heat and changing climate are harming our cultures, our peoples, and our countries. In the article, Mr. Japaruwala says these words on the slide. I'll just give you a moment to read those words. But you can see through those words the impact that perhaps we don't think about. And the concerns he expressed here are widely shared by Aboriginal and Torres Strait Islander communities across the country. Our report shows that climate change is compounding historical injustices and disrupting cultural and spiritual connections to country that are central to our health and wellbeing and our cultural determinants of health. It also highlights that our health services really are struggling to operate in extreme weather with increasing demands and a reduced workforce. All these forces combine to exacerbate already unacceptable levels of ill health within Aboriginal and Torres Strait Islander populations. And here I want to highlight strengths-based discourse, and Lowitja has done some work on, the negative narrative that surrounds Aboriginal Torres Strait Islander health, and that we should not be seen as a vulnerable population, but as a priority population, which really is important to changing the narrative and the focus on the issue, with the issue being the system, not Aboriginal Torres Strait Islander peoples, and how that system affects us, and therefore where we should be, which is a priority. Yet, despite being a priority or a vulnerable population, whichever place you want to place us in, to date, we've not been sufficiently included in national conversations about climate change. And environmental health determinants have largely been absent from the national narrative around, national Aboriginal Torres Strait Islander health policies. There are gaps in research, gaps in data, and most reporting on climate change does not include our voices or our local knowledge. Many solutions are known, amongst Aboriginal Torres Strait Islander peoples, but there is not equal or equitable access to them. And this report finds, importantly, that these issues are inevitably linked to structural and systemic racism. As many of you know, prior to colonisation, Australia consisted of more than 250 nations representing a broad diversity of cultures and knowledges. Central to all of our cultures is an understanding of the holistic nature of health and wellbeing. That good health is dependent on respectful and reciprocal relationships to country, culture, spirituality, community, and family. For at least 65,000 years, we've developed a unique connection and equilibrium with land, seas, and environments in which we live. We took our role as custodians of country very seriously. But colonisation severely disrupted and devastated these connections and our custodianship of our lands. As Maori scholar Dr. Rhys Jones says, from an Indigenous health perspective, climate change can be seen as an intensification of colonisation. Colonisation ignored Indigenous ways of knowing, being, and doing, right down to the weather, insisting that we live according to just 4 seasons, brought here from England, of course, instead of the many seasons our people knew and respected locally. We even had our weather colonised, and in doing so, it threatens to make this country uninhabitable. Ironically, terra nullius, yet again. So if we're honest about truth-telling needed in our country, we must be honest about what made countries sick in the first place. But this challenge brings the opportunity as well, and it brings strength. Climate change presents an opportunity to redress and empowerment of our communities, to lead climate action based on our intimate knowledge of country. And that's why the Lowitja Institute and the NHLF is working with CAHA to spread the word on our discussion paper and its recommendations so that it can have meaningful impact on policy and health outcomes through knowledge translation, which is at the heart of Lowitja Institute's work. We don't just do research for research's sake, we do it for our community and we do it for impact. Our paper maps out clear calls for right-based climate action and place-based adaptation and mitigation. Its 4 high-level calls are the following. 1, take action that respects human rights and achieves equitable health and environmental outcomes for Indigenous peoples. 2, value and centre our knowledges and rights as Aboriginal Torres Strait Islander peoples. We've protected country for millennia and have survived dramatic climatic shifts. Remember, we were here when Australia had its last ice age, and we've survived that. And we are intimately connected to country, and our knowledges and cultural practices hold solutions to the climate crisis. 3, work with us to protect country and do the work on adaptation and mitigation planning. We need equitable access to housing, renewable energy solutions, and our lands and our waters. We need access to that, and a united effort to stop the government ripping every mineral out of the ground. 4, last but not least, create a movement for climate justice. Climate change will affect us all, but some of us more than others. We need to ensure climate action learns from historical truth-telling and commits to not repeating the wrongs of the past. This is climate justice, and it's deeply linked to race relations in Australia. We are the only first world nation with a colonial history whose constitution does not recognise its First Peoples. The current federal government dismissed what was offered by Aboriginal and Torres Strait Islander peoples as a gift to the nation, the Uluru Statement from the Heart. The statement calls for voice treaty truth. In my view, you cannot be taking serious action on climate unless you are acting on self-determination and climate justice. I would love to see each and every one of you at this conference and your organisations and networks to commit to supporting the Uluru Statement from the Heart, integrating its calls to action into your work and putting climate justice at the heart of your work going forward in building a sustainable, equitable healthcare systems. As we work for transformative change so that our health systems are equitable, climate resilient, sustainable and net zero, I want to highlight the work that Aboriginal Torres Strait Islander people and organisations have done to embed cultural safety into the health systems as a blueprint that I offer you for change and a possible learning for greening our healthcare sector. First, let me talk about what cultural safety means and how it's crucial to transforming the healthcare sector to achieve equity for Aboriginal and Torres Strait Islander peoples. I believe it's foundational for any policy that we want to embed into our sector. And then I'll outline our efforts to embed cultural safety in healthcare and how that can show the way forward for us on transformative climate action in and out of the healthcare system. In Australia, we tend to use the words cultural safety and cultural awareness almost interchangeably, but they are different. Cultural awareness is focused on improving the knowledge of non-Indigenous Australians. It others us as Indigenous peoples by examining our cultures, the way we live our lives, if you like. It's a process of looking at us, so the gaze is outwards. Non-Indigenous peoples don't have to examine themselves. This is often, of course, then a comfortable experience for non-Indigenous peoples. Cultural awareness can also sometimes reinforce the simplistic notion that all Aboriginal and Torres Strait Islander peoples are the same. So we can have cookie cutter approaches, broad brushstroke approaches to policy, but we're not the same. And we can see this from Tyndale's map. We are uniquely and beautifully different. And you can never know all there is to know about us. There is no tick list on how to treat us. With cultural safety, however, the gaze is inwards. It's about critical self-reflection, tuning into our racial orators. It's about examining racism, really understanding it. When learning about cultural safety, non-Indigenous peoples are asked to critically examine themselves, their own worldviews, their assumptions and their beliefs. So the gaze is inwards. They come to recognise how these ideas, attitudes and beliefs are formed intergenerationally, the social soup that we live in and we swim in. And it's embedded into our organisations and our systems, into our very structures. Cultural safety asks the non-Indigenous peoples to acknowledge how these views, these assumptions, these beliefs may be harmful to their non-Indigenous colleagues, and then to challenge them, to see what they haven't seen before and unlearn them. Cultural safety unpacks the concept of dominant culture, and I can't fully unpack this slide here, but when you're a member, essentially, of dominant culture, your identity is constantly affirmed and reinforced in ways that you possibly don't even realise, because the structures that are formed and built around you are created by your culture. But for those of us living outside of dominant culture, it can be challenging. As this slide says, and this is my nutshell moment about dominant culture, it's important to acknowledge that when non-Indigenous peoples arrived here, they redefined what was normal and redefined all of the things that, we had to live by. Before I was given the privilege of leading the Lowitja Institute, I was the CEO of the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives, or CATSNM. An amazing organisation. And I was pleased while at CATSNM to work closely with AHPRA and many other stakeholders to launch a new Aboriginal and Torres Strait Islander health and cultural safety strategy. It recognises that cultural safety is a critical component of patient safety. The strategy sets some clear direction and a course of action for AHPRA and the national boards and accreditations authorities who, of course, regulate Australia's health practitioners through. And they're, that all of this is based on legislation. So we were really determined, to affect and embed that legislation with cultural safety. We also worked with peak bodies for nursing and midwifery to embed cultural safety into the new nursing and midwifery codes of conduct, our education accreditation standards, and then to health service standards through the Health Care Safety and Quality Commission. But we faced hysterical and ill-informed reactions. Some of them you can see on the slide here. They were fired up by elements of the media, something that I'm sure all of you seeking climate action will know about only too well, how you can experience backlash from media. But amid that backlash, it made such a difference for us that the nursing and midwifery leadership were solid in their support for cultural safety. And it made a difference that many of these leaders had done cultural safety training and a lot of critical self-reflection. So these non-Indigenous women and men understood about their power and their privilege, and that it wasn't the work of Indigenous nurses to counter the backlash and unpack racism and explain cultural safety. It was their work. Cultural safety is an approach that understands that equity and equality, are different. Equity is required first for equality to be the outcome. And I think this slide explains that beautifully. Equality usually focuses on people getting the same experiences and opportunities to affect the same outcome. This is what, people mean when they say, I treat everyone the same, usually in the name of fairness. But as we know, that can only work if everyone starts from the same place and needs the same help. In contrast, equity is understanding that people come from different experiences, and we need to meet people where they are at and give people what they need to be successful. This is both critical, I believe, in healthcare and in climate action. And the growing focus on cultural safety is now evident in the position taken by many national Aboriginal and Torres Strait Islander health organisations over the last decade. Almost all of them have policy and position statements and frameworks that address racism and cultural safety. Cultural safety has started to gain traction in mainstream, health organisations at a national level too. But words must be translated into action, and here is where allies come in. Allyship and understanding allyship and cultural safety is a lifelong journey, but I encourage you to start that journey today. Aboriginal and Torres Strait Islander peoples represent 3% of the population of Australia's total population. Just imagine for a moment what could be possible if the 97% of other Australians were allies in addressing racism, promoting equity, valuing culture and country, creating cultural safety, and acting to address climate change, particularly in their workplaces. We need multiple voices working together on the same page, but we need governance at all levels that privilege Indigenous leadership, and not just putting one Aboriginal person on a reference group, not just adding a paragraph to a climate strategy about the impact on Aboriginal and Torres Strait Islander peoples. And that's why Kaha's done this amazing work with us. We need authentic involvement, and we need knowledge translation. Like we saw with cultural safety, perhaps we could develop accreditation standards for climate action and a low carbon health system, so that action is hardwired into systems and not dependent on individuals. And individuals leave and go, but if we hardwire it into system, it remains there and enduring. And then that these standards are acted upon, and then they're measured and reported upon. And hopefully this happens publicly. We need to do that at every level. There are opportunities to embed climate action accreditation standards, from RACGP and ACRIM accreditation standards through to the Minister Hunt's office. But we could even embed it in our education systems as well. We have, whole university systems that have accreditation scaffolding around them. Like with cultural safety, if you embed change, it's long lasting. Otherwise, it's just more ticking boxes. And like, in anti-racism work, people may think they're doing great work to little or no effect until they measure it. And we would all benefit with some good examples if we were to do this work. Case studies of how to do well. Communities of practice to show how these accreditation standards can work. And this is, all of this scaffolded around these accreditation standards can lead us, to doing this work well. And we don't know what we don't know. And what is exemplar, without dreaming and coming together through, communities of practice to think about what that looks like. And of course, we need to develop a climate and health workforce to support the work. And of course, assessors of these accreditation standards that know this work. And of course, we need to privilege the voices and expertise of Aboriginal and Torres Strait Islander peoples and organisations. On that note, can I finish by inviting you to one of our signature Lowitja events, which is happening next year, a knowledge translation event to further spread the word on our climate change and Aboriginal and Torres Strait Islander health discussion paper or our report to ensure our recommendations are widely taken up. And I look forward to seeing you all there, and thank you so much for this invitation to join you this morning. Have a fantastic day. Thank you.
Really spoke to me loudly was, where's our gaze? What's our, recognising within self our own bias and so on. And I guess her call to action around the recognition that for 65,000 odd years, our First Nations peoples have carefully stewarded the land on which we have the privilege of participating in today, but in one sense, things have been eroded and fractured because of colonisation, and where that leaves us today in the posture and the gaze that we might bring to the circle, particularly as we're impacted through the arena of climate change. Well, folks, we're about to engage in just an interactive piece where we had planned to have a panel for you, which included both Kate and Janine, but I believe that we're still unable to make contact with Janine to have the online participation in that way with her. So we're going to engage through our Slido medium, and we're going to be looking at the questions that you've been asking us as we've listened in that space. And believe that Kate is still there with us, and we'll be able to throw these questions to Kate. For those of you just wondering where our timing's going, we're going to keep pushing through this session in our Q&A time for another 10 minutes, and then we'll be pausing to have a break, scheduled break, where you can step back and just enjoy a few comforts for a moment and give your mind some time to engage and also look at some of our displays and networks that are out there. But if I can throw you to the screen, the one that's sitting there at the top of our questions, is that the one that I'm looking at the top? I'm just checking with my panel over on the side. How can we get these goals like the NHS in Australia is one question we're asking. I think healthcare workers are keen, but executives, health ministers, etc., have other priorities. Kate, I don't know if you're with us, but we'd throw to you to...
Hi, Bruce. Yes, I am. I can't start. Oh, great. There we go. Starting my video. Can you see and hear me okay?
Yes, we can hear you, Kate.
Yeah,
very
thanks.
well.
Well, I mean, it's a good question. It's sort of, we need, at Northern Sydney, we decided we were looking at a whole bunch of different targets. And then, as you said, we opted for an overall unified vision so that everyone was on the same page and we all knew where we're going for. And so that's why our board endorsed net zero by 2035. Clearly, we need those things at a state and a national level. I think, I mean, there's clearly an absence of federal leadership and coordination on this issue. So like many things, maybe it's up to the states. I mean, I can say that in New South Wales Health now, we're setting up a climate risk unit. Climate risk is one of the Secretary's top 6 priorities. Victoria has had a unit for some time. WA is also setting up a unit, and also in Queensland, I understand. So I think, state-based targets would be really useful. And then probably a network, between a number of states to work together on this issue. I think that's probably the way to go. In terms of getting that, I think, yeah, you should be asking your one thing that people can do is ask your chief executive or your hospital general manager, what's our target for our hospital or our district? This is what's happening elsewhere. This is what we need to do. I think those are, good questions to ask, and often not just one of you, but if you can get together a few clinicians together and make those requests, that helps. and then, you know, see what's happening in your state and ask the same questions at that level too.
Thanks, Kate. Look, Kate, I'm going to direct a question to you that specifically got your name on, and the question from one of our listeners out there raises a question around how can we actually make advocacy and climate training in med schools, hospital education programs and specific training programs part of our core curriculum?
Yeah, well, I mean, clearly that's something that needs to happen. There are a few things going on. So Monash is setting one up. You know, I understand that Notre Dame in Sydney Medical School is doing something, and also in Perth, sort of master's type level program. So for health professionals wanting to scale up in that, I know that, you know, and I've attended myself, the CSH, the Centre for Sustainable Healthcare in the UK. They run a whole series of programs. I've done the carbon footprinting one, the sustainable primary care one. There's a sustainable quality improvement one. And we're getting groups together. University of Sydney got a group together who attended those sort of programs. So there's a few things around for people who want to skill up in, you know, carbon accounting and things like that. But I mean, clearly it needs to be integrated into, you know, into existing curriculums across the board. And so I guess the key point is there are bits and pieces happening, not at the scale and pace yet that we need. But for those who are interested, there are a few things that you can attend, you know, straight away.
Well, it's really interesting that you've spoken into that. And there's another question that's emerging here around when we think about issues that lead to over-testing, is that whole fear of litigation. How do you think this might be able to be changed?
Well, I think what's not well recognised is that every time you have a test or a procedure, there are harms and risks in that, you know, and we see in harmful care, those are people who've been sent for a test or a procedure that wouldn't have done them any good, and they actually end up having a bad outcome. So there's, you know, there's a risk involved in on that side as well. So those things need to be balanced up, you know, and I think any sort of a sensible approach needs to be discussed with the patient, communicated. And often, I mean, if you talk to some of our colleagues who are surgeons and things, they say that actually when they spend time talking to a patient about why a procedure, you know, they wouldn't recommend a procedure and the reasons for that, often patients are actually quite, you know, are relieved and are quite happy with that sort of decision, as long as that the process, you know, the communication process, you know, has been undertaken, they understand the reasons. So I think it's really about communication and then patient engagement and involvement in their care and understanding what the risks and benefits of things are. And, you know, once that is articulated, then you can, you know, in a lot of cases litigation, it's because patients are not, you know, are not involved in the decisions. They don't understand what the reasons are. So I think communication is a big part of that, and looking at both sides of it, you know, the risks and costs of tests as well as the risks of not doing it. Sorry if I answered that.
Thanks, Kate. No, I really appreciate that. And I guess what you're saying, the risk is, you know, the risk is always there, and we can either be driven by fear or we can be proactive in our response.
Yeah, there are risks on both sides. I don't think that's widely recognised.
Yeah. Kate, there's a question here that's coming once again directly to you. How do we actually change the expectation of sustainable healthcare work or projects as volunteer work? So, you know, what does that look like?
Well, I think is the question that, I mean, in my experience, there are so many good pockets of practice going on all around the system, mostly by people who are passionate and engaged, and they're doing things in their own time. They're not actually, you know, sustainability is not recognised as a legitimate part of their work. So I think if that's the question, then I think, yeah, we do need to recognise that. Some of the best models that I've seen are clinicians, for example, who work 3 or 4 days a week in their clinical jobs and then have a day or two dedicated time, recognised time for sustainability projects. I think that's really important. In our teams, I mean, we know that a lot of our, you know, junior medical staff and registrars and things, and anyone with a sort of an appointment in the clinical school or in the universities do want to spend time and have a legitimate part of their time dedicated to research and to certain projects. And so what we're doing is, for interested people, you know, suggesting they do sustainability projects in that time. So I think there's, you know, ways in which things can be incorporated. But I do take the point, I think that, you know, in some cases, so for our sort of senior leads on our net zero teams, what we'd like is for them to have 1 or 2 days a week to dedicate to sustainability, and their role then is to coordinate and keep on track, all the other projects. So I think there's a few different ways around that, but it is an important question.
Thanks, Kate. I'm going to take a couple more questions and then we're going to pause for a bit of a break. But one that's hitting the top of the line up there, not quite at the top, but is the next one down. Question from Nathan. It says, what role do we actually think health and quality standards can play in moving health towards carbon neutrality?
Yeah, I think that's a really important question. You'll see in the UK that sustainability is considered as a dimension of quality healthcare, which I think is a very important approach. You may know that the Australian Commission on Safety and Quality in Healthcare, which sets hospital accreditation standards and also now has new primary care standards, is developing a climate risk module that's, I think, out for consultation at the moment. And the view is that will be optional in the first instance, but that climate risk will be, with a view to climate risk being, as part of mandatory hospital accreditation in the future. So I think that's critical in really legitimising this. And, it goes back to Nick's point. We cannot continue to provide safe and quality healthcare if we don't address climate risk. So it's about building into those standards.
Kate, I know you, before when you were speaking, you were talking about carbon being this new currency that we're going to be thinking and measuring. And there's a question that comes from one of our people around, how does the New South Wales Health have a GHG emissions accounting tool with annual reporting with CEO KPIs?
I think that's a really important question and something we're sort of grappling with at the moment. So our unit is relatively new, but we know that this is something that we'll need to do. All out in New South Wales, it's different local health districts, and increasingly they're going to have to be, everyone's going to have to be asked about their carbon performance, their measurements, and how they're tracking. So we will need a sort of transparent, consistent metrics tool across the state, and indeed probably something nationally. So I actually got a call with Nick tomorrow to talk about, what they're doing in the NHS. I understand they're going to sort of have a central model in the NHS, but it's a critical question, something we'll need to do. It would, Nick's suggestion is that if they do it centrally in the NHS, then allows in their case, the trusts to focus more on the actual decarbonisation work, and they know that that's done centrally. But I think it's a really good question. There are a number of tools around there. There's a Global Green and Healthy Hospitals climate checkup tool. There's other companies who do some carbon accounting. I think the problem with healthcare is quite different. It's not just energy and buildings, as we've seen, but there's so much in the scope 3, in the pharmaceuticals, in the medical devices, and so on, the carbon cost of those things, that we have a sort of particular need, and this is a new space. So I think, in answer to your question, it's something certainly we need to look at. I think there needs to be sort of central, state-based or even national mechanisms to do that, so that it's fair and transparent.
Thanks so much, Kate. I'd ask that our participants out there that are here today, that might just thank you once again for your really invigorating. I've personally been inspired by not only by what you've actually said, but the passion in which you bring that calls us to action in our response together. And I know we're incredibly valued what you've been able to speak into in this way. So thank you so much. We are going to move towards a break now. And as we do that, for those of you that have been raising questions in our Slido feedback platform, particularly to some of the other speakers that have been providing input today, I've been talking to our little organising team on the side, and the word is that we will try and address some of those questions back to you in other ways post our forum today. We'll look at ways that we might be able to do that to honour the questions that you've been raising and continue that interaction in that way. But we are going to take a break now. I believe that we're aiming to be back by 10:35. No, 10:30? 10:30 precisely. So that actually gives you 20 minutes to have a break. As you do that, can I encourage you to check out the posters online or in person? We'll be asking you a little bit later on today to actually vote on your favourite People's Choice Award that will be there in the offering, with a winning poster announced at the end of the day. So please participate in that. You can do that online or you can do that in person. And those of you who are here in person, go and visit some of our stands as well. and the way in which they're contributing to sustainable healthcare. So enjoy your break. Don't forget those masks as you walk around. You'll need to put those back on, and we look forward to seeing you back right sharp on 10:30.